Now, according to the South African National AIDS Council, South Africa still has the largest HIV epidemic in the world. We account for a third of all new infections in Southern Africa, with about 7.7 million people living with HIV. Although COVID-19 vaccines are being developed, there's still no vaccine for HIV/AIDS. Despite that, however, many positive strides have been made. Well, to have this conversation with us tonight, we're joined by Steve Litzike, who is the co-chairperson of SANEC, Qoqeka Nokuduka, who is SANEC's executive manager, and Dr. Mbulawa Mugabe, who is the UNAIDS country director. Good evening to all our guests, and thank you so much for your time tonight. I think maybe let me begin with the representatives from SANEC, who can just give us a broader picture in terms of where the country is right now. I think a lot has been said throughout the day about some of the progress that we have made, but we've just come out of that story that Zikona did for us, where it is the lived experience of people, and often we are seeing that the societal context in which people find themselves in has a significant bearing on whether or not they're able to fully fight HIV once they're infected. Steve, maybe let me begin with you.
Thank you so much. Good evening to the viewers of Newzroom and to my fellow panelists. Indeed, it's a big concern for us. 7.7 million HIV, but also South Africa has the biggest HIV treatment program with 4.5 million people on it. We want to get more people on treatment. We want to make treatment accessible. We also want people to adhere to treatment, and also that we suppress the viral load. But there are many challenges, and these challenges include social and structural drivers. These challenges include human rights violation, stigma and discrimination, the drug stock out in the health system, but as well as how we make sure that services are adequate and competent. And these are some of the concerns that we've had as the National AIDS Council. But the biggest issue as the National AIDS Council time is how we need to localize community-led intervention, because HIV, it's not alone. We have to speak about TB, we have to speak about STI, and we have to speak about COVID as well. So we are fighting many dynamics, many epidemics, including non-communicable diseases and gender-based violence.
Can these community-led interventions work without supporting some of the community organizations which we know have been, in many respects, the backbone of ensuring that there is a level of HIV treatment within communities?
No, indeed. I mean, look, one of the biggest challenges we've raised over the years as SANEC is collaboration between government and civil society. We know for the longest time that government will not achieve this alone. That's why civil society is equal partners to this HIV response. But we also know that civil society depends on resources. And if we take resources where they matter and
we seem to have lost Steve there. Qoqeka, let me bring you in here, and perhaps if you can maybe just give us some of the breakdown of numbers that we're dealing with right now when it comes to the HIV infection rate. And one of the things I'd like you to do is really break it down in terms of demographic and age groups, because I think it's important for South Africans to know the scale of the virus that we're dealing with and who is really dealing with it.
Thank you very much, Kathy. Good evening to your viewers at home, and good evening to my fellow panelists. Kathy, as you've indicated, the data is telling us that we've got about 7.7 million people living with HIV in South Africa. And of those, 4.8 million are adult females of 15 years and older. So close to more than 50% of people living with HIV in South Africa are females. If we want to look at new infections, we are contributing about 201,000 new infections every year. Kathy, that's quite a huge number, because this number means our people living with HIV number will be increasing close to 200,000 each year. And of that 201,000, 121,000 of those are women. So you can see in terms of the burden of disease, women are more vulnerable to HIV than males. In terms of looking at age groups, we've seen that female age between 35 and 39 years, as well as females age between 30 and 34 years. So that age group between 30 and 39 is has the highest number of people that are living with HIV in South Africa, followed by adolescent girls and young women, which is the age group between 19 and 24. So you can see, Kathy, that women, younger women, are much more vulnerable to HIV than the rest of the population. Also, we've seen increased in HIV new infections among sex workers, among MSM. Therefore, when we talk about data and we talk about investing our resources where it matters, we really need to focus on key populations for us to reach epidemic control by 2030.
You know, when you look at these numbers and you talk about women between 30 to 39 years old, between 18 to 25, these are effectively, age groups that are supposed to be the next generation. These are people who are still going to live at least another 40 years. What happens if we aren't able to reduce this infection rate at the rate that it is taking place currently?
Kathy, in terms of HIV incidence, which is new infections reduction, between 2010 and 2020, our target was to reduce by 75%. By end of the year 2019, we were at 56%. So our progress towards reducing the new infections is not on track. Therefore, we need to focus on that. If we continue to have these high new infections, Kathy, we look at, if we talk about the resources that are available in the country to respond to the epidemic, therefore we mean that it is not sustainable. We would not be able to continue carrying the load of ensuring that close to 10 million people would continue to be in HIV for the next 20 years. Because at the rate new infections are going, our number of 7.7 million would catch up with us. And as a country, we would not have enough resources to ensure that we continue to treat the people that are infected. But as you've indicated, this is our economic viable age group. Therefore, it will mean the country will also be limping in terms of the economic outlook and the workforce if we continue to have high infections among these age groups.
Dr. Mbulawa, you are the country director for UNAIDS, and this target of reducing of eradicating, it seems almost impossible to talk about eradicating HIV/AIDS by the year 2030 now when we look at where we are, but certainly of reducing the infections. Why do you think it has been so difficult for us to be able to do that?
Thank you. I think part of the problem is that we have not been targeting our programs in such a way that we'll be able to get the dividend from the investment that we are making. I think, as Dr. said, I think it is clearly the infections is located in certain populations. That's where we need to focus our attention. We need to be very clear on what are the strategic interventions that are needed for the different groups. For the first time last year, we reported as UNAIDS that for the first time in the history of this epidemic, we had more infections, more than 50% of all infections globally were from key populations. So we need to start focusing on those areas where we need to make a difference. And I think one of them, of course, in our region and in South Africa in particular, we focus on adolescent girls and young women. But I think we also need to pay attention to key populations. Female sex workers in South Africa have infections that are 7 times more than the adult female population. They have 4 times infection more than the population that we're worried about, which is the adolescent girls and young women. So we really need to be very clear on where we are going to make an impact in terms of the investment that we're making. But let me also point out that we can never sustain this response globally and in South Africa in particular unless we crack the issue of prevention and new infections. Because, you imagine that anybody who goes into treatment today, because we don't have a cure, they are in it for the long haul.
For the rest of their lives,
yeah,
effectively.
So we can't afford to continuously on an annual basis add the numbers that we are adding. Yes, it's true South Africa has made progress in reducing new infections compared to other regions. For instance, between 2010 and 2019, South Africa new infections declined by 51%, vis-a-vis 23% globally. So you can see that there is progress, but it's not sufficient for a country that has the kind of disease burden that we have.
Steve, I'm going to come to you next, and you can also just give me your closing remarks as we get ready to wrap up this conversation. Dr. Mbulawa raises a very important point around key populations that need to be targeted. And often when this conversation is put on the agenda, there are lots of other things that get in the way of it moving forward. So the minute you talk about paying attention to sex workers, people raise the issue of criminality, of illegality of sex work. Should it be decriminalized? And that seems to be a political hot potato that has been going back and forth for some time now. How do we still ensure that those populations are not neglected as the politics continues? Because we can't wait for the day that government decides to decriminalize sex work before it is, given the kind of attention that it needs.
Look, I think the most important thing is not to ignore the reality. We have a constitution, and we have a constitution to protect that guarantees the life, protection, security, freedom, as well as equality. Sex workers are people, and they are working, and they are consenting adults, and we need to speak about the history of colonization of criminal laws. Criminalization, like we've done in the where we've criminalized Black people not to come to other sections of our cities, our towns, or whatsoever urban areas. But the same way we've criminalized women that can't drive, the same way we've criminalized same-sex practicing people, that it's criminalization. So similarly with sex work, we need to decriminalize. That's the position that we hold as South African National AIDS Council. This will help us in the prevention agenda that Dr. Mbulawa is talking about. Secondly, we cannot gamble with people's life. The rights are entitlement, and that means these entitlements belong to everybody in South Africa. And that means we need to fight against and push back in some of the social dynamics. Some of the issue that is being compromised at the moment, it's also the comprehensive sexuality education, which is part of the curriculum that has been implemented since 2000 in South Africa. But here we are, we're seeing religious groups, we're seeing more and more people pushing back and saying, do not speak about comprehensive sexuality education. But yet our young people do not have the correct information that helps them to make decisions that are correct and that are informed. And we have this big challenge. Stigma and discrimination is big. Human rights violation is big. But for us as South Africa, we need to be bold, we need to be very strong, and we need all sectors to come to the play as we respond to the HIV. Prevention is big, same as treatment.
Look like very briefly from you, perhaps your closing remarks.
My closing remarks would be to say, as we focus with the country going towards 2030 to meet the National Strategic Plan targets, we also need to make sure that children that are HIV exposed continue to be taken care of. We continue to make sure that those that require treatment are on treatment. And I think the message is the same. The cornerstone of our HIV prevention messaging is condom. So condomize, condomize, condomize. Thanks, Kathy.
Dr. Mugabe, you'll have the final word here tonight.
Well, I mean, just to say that I think because countries have fallen behind their targets, not just because of COVID, but even before COVID, countries were already struggling to meet the targets. UNAIDS is calling for countries to have more ambitious targets to try to close the gap in terms of what we need to achieve between now and 2025. And we're going for targets that will be looking at 95 instead of 1990. But in this case, particularly very nuanced around all the population groups that we're talking about. If we want 95% of adolescent girls to have full coverage of services. We want sex workers to have full coverage of service. In other words, we are not going to measure at population level. We have to go by location. Where are we in districts? Where are we in metros? Where are we in each of the age groups? So I think that's the way going forward. But I think countries can actually catch up. If they commit to some of those commitments.
It also means doing greater work, because currently we don't have the breakdown of figures down to a district levels, statistics. So I think it also means greater work from the local government space. Let me thank all of my guests this evening. Steve Litzike, who's the co-chairperson at SANEC, Koteka Noguduga, who is SANEC's executive manager, and Dr. Mbulawa Mugabe, who is the UNAIDS country director. We certainly didn't have enough time for this. So much more that is left to explore, but thank you all for tonight.